This is really just a very quick, brief overview of basic GI symptoms and specifically constipation, which of course is one of the most common, or probably the most common GI disorder that gets treated. So essentially, when you're thinking about gastrointestinal disease, one of the important things to really think about is your anatomy. A lot of times with our nursing assessments, we tend to focus on different parts of the abdomen. So as we're auscultating bowel sounds around the abdomen, as we're palpating lightly around the abdomen, as we're percussing around the abdomen. When you think about the different quadrants, think about the structures that are in that quadrant, so that when you percuss or palpate and it elicits pain or it elicits a change in sound, from something tympanic to something dull, think about the structure that you're actually palpating or percussing over. And generally, that's where the disease is probably lying. So, kind of get a sense of, your basic GI anatomy. So, what are some symptoms you're going to see in patients? Well, there's a lot of generalized symptoms. Nausea, vomiting, and abdominal pain are. Abdominal pain specifically is one of the most common complaints that causes people to come to the emergency department, right? So, and it's described in a variety of different ways. So nausea is really a subjective experience. It's the subjective experience of the patient in relation to potential vomiting. So a lot of things stimulate nausea, like abdominal pain or stimulation of the labyrinth of the inner ear that can produce like a spinning sensation, causes nausea. Generally, tachycardia and hypersalivation accompany nausea. So you usually have nausea, and that's generally followed by a retching. And retching really is the precursor to vomiting, which is essentially forceful emptying of stomach contents. So retching occurs when you take a very deep breath, and closing of the glottis when you take that deep breath decreases pressure in the intrathoracic cavity. The esophagus becomes distended, and at the same time, your abdominal muscles on the bottom are actually contracting and creating a pressure gradient between the abdomen and the esophagus. What happens when that pressure gradient changes is it forces the lower esophageal sphincter to open, and that forces chyme into the stomach, from the stomach, into the esophagus. Now, the upper esophageal sphincter is closed, so you don't actually vomit. You tend to feel that sort of chyme that's coming up into the to the esophagus. It might give a sensation of a taste in the back of your mouth that makes you feel like you're going to vomit. But with retching, you don't actually vomit. The abdominal muscles relax, chyme will flow back into the stomach, but this process continues during this period of retching. There's some stimulation of the sympathetic nervous system, so in this period of time, you tend to have some tachycardia, some tachypnea, and diaphoresis. And if you've ever had that feeling that you're going to throw up, many times you'll feel palpitations. Many times you'll feel very sweaty, you get clammy. So as the stomach is filling with gastric contents, the diaphragm is actually forced upward into the thoracic cavity. Again, this is going to increase intrathoracic pressure, and this is what forces the upper esophageal sphincter to open, which actually causes vomiting. All right, so vomiting can be spontaneous without nausea or retching, and that's where most times vomiting occurs because of nausea and retching. But spontaneous vomiting that occurs without nausea can sometimes be concerning. Projectile vomiting's one of the very specific disorders that we worry about, because when we think of projectile vomiting, this is forceful vomiting, like vomiting literally across the room, we think of increased intracranial pressure. That's direct stimulation of the vomiting center in the brain. You can also have vomiting without nausea because of pyloric stenosis, okay, where the pylorus, the part of the stomach that connects to the duodenum, is actually stenosed, and there's been a backup of contents into the stomach. Constipation is another very common symptom of GI distress. Constipation is a decrease in the number of bowel movements per week, a decrease in the frequency of bowel movements, hard stools. You might be moving your bowels every day, but the stool is very hard, or difficult evacuation of the bowels. Okay, so it can be, constipation encompasses a variety of different things. Normal stool should be 1 to 3 times per day. Believe it or not, we should actually evacuate our bowels 1 to 3 times per day. Things that cause constipation are functional, where there's an actual decrease in peristalsis, where transit time of contents is low. Diet, right? Low residue diets, refined foods that don't promote bulk in the stool, that all decreases activity. Those tend to linger in the stomach and the GI system longer. They're harder for the stomach, or they're harder for the intestines to process. So that sometimes we have a decrease in activity. Again, that all sort of puts our guts to sleep a little bit. And lastly, there's suppression of the urge to defecate. Now, you see this in kids a lot, where kids don't want to use the bathroom for a variety of reasons. They're afraid, and so they tend to hold it in. And what that actually does is changes the tone of the sphincter, making it harder to actually evacuate your bowels when you need to. This happens in adults too, you know. People go to a theme park, they don't want to use the public restrooms, and so they hold it, and then they go home, and then they can't go. So it is unfortunately something that does occur. Dehydration can also cause constipation, where there's lack of water to be able to form stool, and then also things like narcotic use. Those can make the bowel sleepy. So any kind of, benzodiazepines, narcotics, anesthesia, those all just make the guts sleepy, and so that reduces peristalsis. And so if there isn't peristalsis, there isn't going to be the ability to move stool through the colon. Diarrhea is another very common symptom of GI distress, and that's an increase in the frequency of defecation and in fluid content and volume of the stool. So it could just be simply that the patient is going more often, or it's that the volume of stool that's produced is very watery. More than 3 bowel movements per day is considered abnormal. Normal adult stool volume is about 200 grams per day. Okay, so we can tell a lot from a patient's stool. Diarrhea is important to look at because, if is it mostly water? Is it undigested food? Is it full of fat? Is it bloody? So we do tend to, as a nurse, look at GI contents for helping us sort of pinpoint things that might be happening in the patient's GI system. Pain is a common symptom of GI distress. There are so many reasons to have abdominal pain. There is obstructive process that is usually from something mechanical, where you have a little obstruction, you have inflammation, and that causes a lot of GI distension. Where you have edema that causes stretching of the intestines. You can have ischemic problems where you have like the mesenteric artery that brings oxygen to the colon can become occluded. That causes ischemia to the intestines, which can cause necrosis of the gut. People tend to describe abdominal pain in a variety of ways. If you have mechanical, inflammatory, ischemic, sometimes they'll say it's sharp, it's colicky, it's crampy, it's dull. So again, quantifying and asking patients when you're evaluating pain what the pain feels like can sometimes clue us into what's happening in the intestines. Parietal pain is very somatic. Parietal pain arises from the peritoneum. That's a little bit more localized to the abdomen. It's very intense. Things like peritonitis, where you have inflammation of the peritoneum, can cause a parietal pain. Visceral pain comes from the actual organ itself. So like if there's distension of the colon or there's inflammation of a specific organ. A lot of times with visceral pain, it's very vague. It's usually diffuse and may have sort of a radiating pattern. So again, the different types of pain that people have is really important to get when you're doing a full nursing history, is to really get them to quantify the pain and really describe the pain. Referred pain is generally visceral pain that's felt at some distance from the affected organ. For example, acute cholecystitis often refers to the right shoulder. Pancreatic pain is often felt in the back. Ovarian pain is often felt in the shoulder of the same side. So a lot of times, because of the innervation of nerves that run through the whole abdominal cavity, you might have patients with referred pain. So specifically for this lecture, video lecture, I want to talk just about constipation, a very common, one of the most common GI disorders. Again, constipation is described as a lot of different things. People tend to think of constipation as a decrease in frequency, but it's more than that. So people spend hundreds of millions of dollars on laxatives every year. The principal, if you think about the principal function of the colon, that's really to absorb water and electrolytes. Absorption of nutrients is actually minimal in the colon, in the large intestines. Normally, it's really water. We have about 15 milliliters of water enter the colon every day, and 90% of that water gets absorbed in the large intestine. So when the colon isn't working correctly, the extent of fluid absorption is such that the stool is generally, when the colon's working properly, fluid absorption is important because the resulting stool from the amount of water that gets reabsorbed in the colon makes the stool very soft. So it's usually formed, but it's soft, and makes the patient capable of elimination without strain. That's really the key factor in constipation, is that that regardless of the mechanism of the constipation, that it forces patients to strain. So when fluid absorption is excessive, that's when you get very watery stool, and that's when you get diarrhea. But when fluid is insufficient, then you get a very hard stool. Frequency is very individual for patients. For some people, bowel movements occur 2 or 3 times a day. For others, elimination may occur, 3 or 4 times a week. We can't really define what a normal frequency is for a patient. Whatever your daily bowel movement is, it's probably normal for that person, but it may be abnormal for others. So it's really important to know that if your patient moves their bowels twice a day, and they are now moving their bowels every other day, that's a change in their normal pattern. Okay, so proper function of the bowel is really highly dependent on water, but also on dietary fiber. So the component of vegetable matter that escapes digestion in the stomach and small intestine is really what dietary fiber is all about. Fiber facilitates the function of your colon in 2 different ways. First, fiber absorbs water. So again, we have a lot of water flowing in and out of the colon, but because you have fiber in the colon, the large intestine, it's going to absorb water. Thereby, it's going to soften the feces and increase the mass of the stool. Fiber can be digested by colonic bacteria, and then the bacteria actually grow, and that increases fecal mass as well. So the best source of fiber is actually bran. We can also get fiber from fruit and vegetables. We should have 20 to 60 grams of fiber per day. That's really the optimal amount for proper bowel function. So what happens when we don't have that? We start to take laxatives. As you can see from this list, there are a lot of different kinds of laxatives. So it's going to be important that you learn the different categories. Again, you have bulk forming. Those, again, a bulk forming laxative, if you just think about that, it requires you to put bulk in the stool. So a bulk forming laxative frequently requires a lot of water. So then there's others. There's stimulant laxatives that actually stimulate peristalsis. There's osmotic laxatives that, again, retain water, making the stool much softer to pass. So there's a lot of different kinds of laxatives on the market. The type of laxative that's, from a clinical perspective, it's kind of useful to classify laxatives by like their clinical therapeutic effect, which really has to do with how fast do they work and how do they impact the consistency of stool. So when you kind of figure those things, you actually have 3 groups of laxatives that produce a stool within a certain time frame. This is actually really important for nursing because in the hospital setting, we frequently need to put patients on bowel regimens. People aren't moving as much, there's decreased peristalsis, they may have had surgery, they may have GI disorders that are causing constipation, they're not eating as well, the food isn't as good, so they may not be taking in as much fiber. So if your patient really, when you're talking about a bowel regimen, if your patient really hasn't had a bowel movement, you need to think about how quickly do we need them to move their bowels, right? Because the type of laxative that we choose, and many times physicians or other licensed providers will simply order a variety in a package, right? They'll look in their order set and they'll order, an osmotic laxative. They'll order, a stimulant laxative, and they may order a bulk forming laxative. And it's really up to the nurse to kind of choose. A lot of times, based on the results, what we're going to give the patient. Okay. So many laxatives are either given daily or as needed. All of them will cause diarrhea, flatulence, and bloating, so it doesn't matter which one we choose. We do have to be very careful that if we produce large stools, that we watch for dehydration, electrolyte disturbances. So again, no matter what type we give, they all can cause dehydration because they all can cause diarrhea. Group 1 agents tend to produce a bowel movement pretty rapidly within about 2 to 6 hours. They give a very watery consistency to the stool. Laxatives in Group 1 are really useful, like when we have to prep the bowel for surgery or diagnostic procedures. Group 2 produce a semi-solid or semi-fluid stool in about 6 to 12 hours. They have like an intermediate action. They produce a stool that's sort of semi-solid and makes very easy to pass. Group 2 agents are ones that are frequently abused by the general public. Group 3 laxatives act a little bit slowly. They don't produce a bowel movement for a day or two. They produce a soft but formed stool. When we treat chronic constipation, we can, a lot of times we use Group 3 products because of the chronic nature of the constipation. So when we look at the types of laxatives specifically, we have the bulk forming laxatives, right? Very common. This is very similar to dietary fiber. These are things like psyllium and metamucil. They have the same impact on bowel function as dietary fiber does. So if you ate a bowl of bran, it would be the same as taking powdered psyllium or metamucil in a glass of water. So following ingestion of these agents, they are non-digestible and non-absorbable. So what happens is you put them in water and they swell in water. They form a viscous solution that softens fecal mass and increases its bulk. So fecal volume, this just creates a larger fecal volume. And it increases transit time because it increases peristalsis. When you take these, you usually have to take them with a large amount of water. And because they swell in the colon, they increase peristalsis. So we take it with water, we take it with juice, and that helps us prevent intestinal obstruction. If we do not take this with enough water, then what's going to happen is the fecal mass, the mass of the swollen medication kind of gets stuck in the small intestine, and that can actually create an obstruction. So it's very important that we do give these with a large amount of water. So we use this it's a temporary treatment for constipation, although patients will take them daily on a long-term basis when they have chronic constipation. Surfactant laxatives simply lower surface tension of the stool, which makes it easier to pass out the rectum. They stimulate secretion of water and electrolytes into intestinal lumen, and so they basically just make the stool that you have in there a little more slippery. One of the very common ones, this is Docusate or Colace. They, again, produce a soft stool, and they just make the stool easier to pass. They have to be taken with a full glass of water as well, because they don't cause as much obstruction as the bulk forming laxative, but they do need a lot of water for absorption. You have your stimulant laxatives. These are things like bisacodyl, Dulcolax, your Senna, your Senecot, your X-Lax. They have several effects on the bowel. First, they stimulate intestinal motility, hence their name, stimulant laxatives. These are the ones that get abused because the bowel peristalsis becomes dependent on the laxative. So they really should be used very short term. But they stimulate intestinal motility. They also increase the amount of water and electrolytes within the intestinal lumen by causing water to be secreted into the intestine, and so they actually act on the colon to produce again a very semi-solid kind of stool. They work in about 6 to 12 hours. Widely used. They are unfortunately a concern for the general public because they do become addictive, and they are really helpful when you have opiate-induced constipation, and when you have constipation because of slow intestinal transit, then they're really, really helpful. Many people believe that a daily bowel movement is a prerequisite for good health. You find this especially in the elderly population, and so that if there's a deviation from that pattern, then it has to be corrected. So a lot of people use an X-Lax, for example, because they feel like, they get up in the morning and they should have a bowel movement, but if they don't, then something must be wrong, and so they tend to take a lot of over-the-counter laxative preparations. So unfortunately, and they're advertised a lot, so people tend to use them. A lot of times these work really well when you give them at night. Because they usually will then produce a bowel movement in the morning. They should be taken with a full glass of water so that, again, you don't get obstruction. Okay. Castor oil is really helpful when you need rapid evacuation of your bowels needed. Castor oil, not a laxative we use in the hospital very often, but you will see people use this in the home environment. It is an oil, and it basically can be helpful, like when you need to, let's say, have a radiologic procedure done and you need to evacuate your bowels quickly. You shouldn't be using this routine. It is frequently used to promote labor. That is one of these sort of off-label uses, that sort of home remedies that people will use it for. And you have your osmotic laxatives. These are things that cause a substantial loss of water. They pull a ton of water into the colon, and they produce a very, very soft fecal stool. And they actually stretch the colon wall. They increase peristalsis by doing that. There are a couple. You have your Miralax, your polyethylene glycol. That is very commonly used. You take 17 grams of it. It's a very fine powder. It's dissolved in 8 ounces of water or juice. And so Miralax is very common because, again, it produces a very soft, mushy stool that makes very easy to evacuate. You have magnesium salts, which are liquids. They're citrated magnesium hydroxide. They are just simply, because it's basically water, they pull more water in, and so they produce, again, a soft, mushy stool. The other osmotic laxatives that are on the market are things like Go Lightly. That is a large volume. You take about 240 milliliters, so like every 10 minutes until about 4 liters of this is ingested, and that actually produces literally clear rectal effluent, which is clear stool. We use that to bowel prep. So there's a lot of different osmotic diuretics on the market. There's one other one I was thinking about. Lactulose is another one. I'm going to reserve talking about lactulose until we talk about the liver, because although it is a very good medication to relieve constipation, it is frequently used for the removal of ammonia in liver disease. So this is just basic overview of constipation, and we'll talk about the rest in class later.